So quickly over the next 15 minutes, I'll just give you the concept of sarcopenia frailty, a little bit about the diagnosis, what is the gold standard for diagnosis, and what are the treatment options available to us for treating frailty and sarcopenia. So sarcopenia and physical frailty are two sides of the same coin. I think we all would agree to this. The central component to both these conditions is physical function impairment. And when you're looking at the muscles, the quality or the mass, then you say that we're looking at sarcopenia. Whereas frailty is a complex syndrome which involves multiple physiological systems. And both these conditions have emerged as an independent predictor of poor prognosis in cirrhosis as well as post-transplant survival. So let's look at the definition of sarcopenia. This is all which has been extrapolated from the geriatric population. So this was in 2010, the European consensus guidelines, and they suggested that sarcopenia should be defined as low muscle mass with either low muscle strength or low physical performance. But over a period of time, they realized that this is not enough. And this definition was revised in 2018 because they found that mass is not just important. The quality of mass, the strength and physical performance all are important. So they reversed the definition here now. Now the definition of sarcopenia in this consensus was low muscle strength, which is central because muscle mass would vary from population to population, gender, as well as ethnicity. So central is low muscle strength. And if with this you have low muscle quantity or quality is we're talking about myostatosis, and or low physical performance, then we label them as sarcopenic. So what's the definition of frailty? It's defined as a biological syndrome of decreased reserve and resistance to stressors resulting from cumulative decline across multiple physiological systems. And this causes vulnerability to adverse outcomes. The central component of frailty is again sarcopenia and malnutrition. And when other systems are involved, like you have functional decline, physical deconditioning, you have cardiopulmonary dysfunction or cognitive dysfunction, then you label them as having frailty. So let's just move on to the diagnosis. I'm just going to talk about the gold standard. The gold standard for diagnosis of sarcopenia is the L3 SMI. You look at the cross-sectional area of the skeletal muscle at the level of L3. And these are the cutoffs which have been suggested by the North American Consortium, a cutoff of 50 for men and 39 for women. And this was based on a large retrospective study of 5 centers in North America that included 396 patients. And they saw that there was significant difference between patients who were sarcopenic. There was a significant difference in survival in patients who were sarcopenic as compared to the non-sarcopenic group. There are a lot of studies which are available now, and a lot of different cutoffs have been suggested. BMI-based cutoffs have also been suggested, and ethnic and population-based cutoffs have also been suggested. The basic premise is that the muscle mass would vary from population to population. So let's look at the Indian data. This is the normative values of sarcopenia, which was, this study was done by Dr. Sidhu's group from Ludhiana, and they suggested that mean SMI is around 44 in men and 41 in females, and this was based on abdominal CT imaging, which was done for acute abdomen in patients in DMC Ludhiana. So what does the INASL suggest for diagnosis of sarcopenia? The SMI cutoffs have been 42 and 38 for females, and this is based on the Asian cutoffs, Japanese and the South Asian cutoffs, which have been derived from various studies. How do you assess muscle strength? The best and easiest, simple and inexpensive test is the hand grip, and it has been seen in studies that it helps in prediction of major complications and mortality. So these are the BMI-based cutoffs, which were suggested way back in 2010. The recent cutoffs are 27 and 16 for men and women. And there is some data on hand grip tests for assessment of patients with decompensated as a screening tool. And this data was generated from our institute. And they showed there's a good correlation between the CT-SMI as well as the skeletal muscle index. And they derived a cutoff of 31 in males as a good screening tool with a high sensitivity. I just want to focus on this very interesting paper, calf circumference. It's very difficult to do CT scan in all your patients. hand grip strength is a good screening tool. Another test which can be used in day-to-day practice, even in ICUs, is the calf circumference. This is a Japanese studies, 525 patients, and they looked at sarcopenia by BIA and hand grip strength, and we compared it with all the anthropometric other parameters. And they showed that the calf circumference has the highest area under the curve for diagnosis of sarcopenia, and they derived a cutoff of 35 and 33. Simple, can be used bedside test, can be used in ICU patients also, but we need more data on this. So let's move on to frailty. Multiple composite scores have been suggested. The feed frailty score was the initial score which was being used. Then you have this clinical frailty scale. The most accepted out of this is the liver frailty index. And two simple tests which I will talk about is the 6-minute walk test and the gait speed. Liver frailty index, in this you look at the hand grip strength, the chair stands, and the balance testing. And if the LFI is more than 4.5, you label them as frail. If it is between 3.2 to 4.5, they are pre-frail, and if it is less than 3.2, then it is robust. So this was based on this, again, a good study by Jennifer Lai et al., and they looked at 536 patients, and they showed that survival of patients is better predicted if you use the MELD sodium and the frailty index. So let's look at this simple test which can be used for assessment of frailty. Gait speed, a very simple test. The way the patient walks into your OPD is a simple test. You can assess your patient whether he is frail or not. A single cutoff speed of 0.8 is an indicator of frailty. And 6-minute walk test, just a simple test. You can just ask the patient to walk for 6 minutes, and if it is less than 400, then it suggests that the patient is frail. So let's just move on to the treatment part. There are a lot of targets for treatment which have been identified: hyperammonemia, pro-inflammatory cytokines, portal hypertension, the hormone levels, and physical inactivity. So I'll just focus on a few concepts here. Non-pharmacological treatment which have shown benefit are nutrition and exercise only. Lot of drugs are in the pipeline, but few drugs which I'm going to discuss is, one is branched-chain amino acids, L-carnitine, and there's some little data on use of tips and other drugs. So nutrition is very important for all our patients. I think we should all suggest that all the patients of decompensated cirrhosis should receive high calorie, high protein diet, and they should get complex carbohydrates. They should be given late evening snack, and frequency of meals should be at least 5 to 6 meals per day. I'll just show you this randomized trial which we have done in PGI. This was done in decompensated cirrhotic patients, and 50 patients in each group. And we gave them home-based intensive nutrition therapy, 3 meals plus 3 snacks. This was a dietitian-based program, and the diet was based on whatever they had at home. Look at the results: significant improvement in frailty at 6 months. And patients who were compliant to the treatment had a better survival as compared to the patients who were unable to reach that calorie and the protein intake. So obviously nutrition is very important, and it's easy to do also. Let's move on to exercise. You are trying to improve the peripheral and the central adaptation in these patients. Exercise capacity is described as the ability to use oxygen during exercise. And in cirrhosis, you have low mean VO2. They have a low aerobic endurance for activity, and reduction of each of these measures correlate with the increased mortality. Lot of trials are there. I'll just show you this meta-analysis. The crux is, the bottom line is that there is a consistent improvement with whatever exercise you suggest. The aerobic endurance improves, and muscle mass and strength also improves. How do you tell them to do exercise? It has to be slow, progress slowly, and this is the FIT principle which can be used in the patients. Aerobic resistance and flexibility exercise should be suggested to all your patients, and this has to be gradual, increased over a period of time. Let's move on to the drug therapy, branched-chain amino acids. Theoretically, it appears that branched-chain amino acids would work in all the patients, but however, the data is conflicting. This is a large meta-analysis which shows that it helps in improvement of the skeletal muscle index and the mid-arm muscle circumference, but there was no improvement in the hand grip and the triceps subcutaneous fat, suggesting that the frailty might not improve in these patients. Another randomized trial from the AIMS group, and Dr. Sarai has done this trial, 60 patients who were given branch chain amino acids, they did not find any significant difference in the skeletal muscle index at 6 months. No change in the hand grip strength, gait speed, and the 6-minute walk distance, which are suggestive of no improvement in frailty. What are the other drugs which are available? An interesting drug. This is beta-hydroxybutyrate. This is an active ingredient of leucine. This data is from the geriatric population. 9 RCTs and 896 patients in this meta-analysis. They showed a significant improvement in the muscle mass in both the pendicular as well as the limb muscle mass. However, there is no data in patients with cirrhosis of this drug. What about L-carnitine? It is an important nutrient which is required for the fatty acid metabolism. It enhances the transfer of acyl CoA into the mitochondria and enhances the ammonia clearance to increase ureagenesis. This study was done in 52 patients, the preliminary study in cirrhosis, and this was a retrospective study in which they looked at what was the effect of carnitine on muscle mass. This study showed that there is an increase in the muscle mass with only high dose of L-carnitine. However, you have a meta-analysis now which suggests that 12 to 24 weeks of L-carnitine supplementation alone does not increase muscle mass. And there is an active component of this drug, which is trimethylamine N-oxide, which is considered atherogenic. So we do not have good data to support the use of this drug in patients with liver cirrhosis so far. Let's move on to the hormonal therapy. Testosterone has been tried. This was the first study in 16 hypogonadal men with liver cirrhosis, and they used this testo gel for 6 months. They did show an improvement in the hand grip strength. Then came this study by Sinclair et al., and they did a randomized trial. Group 1 received IM testosterone for 1 year, and Group 2 received placebo, and they showed a significant improvement in the muscle mass in these patients. The only caveat here is that testosterone can lead to increased malignancy risk and HCC, and this has not been replicated in further studies. So we need more data on the use of testosterone in patients with cirrhosis. So just to summarize, I've talked about BCAA, I've talked about L-carnitine, a little bit about testosterone and hormonal therapy. What are the experimental drugs which would be available in the future? Myostatin plays a very important role in the pathogenesis of sarcopenia frailty, and you can just look here that myostatin antibodies which target myostatin would be available in future, and there are some trials which are going on the use of this myostatin antibodies. Other myostatin inhibitors, polystatin is one drug, and anti-myostatin adenectin and polypeptides are being tried in clinical trials so far, but we do not have good data on patients with cirrhosis. Reduction in portal hypertension by TIPS is one study where they showed improvement in sarcopenia, but we need more data on that, and you cannot recommend it as a first-line treatment for patients with sarcopenia frailty. A little bit about ghrelin agonist, which improves the nutritional intake of patients, but still no data is available. But future looks good, and maybe over a period of time, we will get more drugs which might help in the improvement of sarcopenia frailty in patients with cirrhosis. So let me just conclude here. Sarcopenia and frailty are two sides of the same coin, frequently unseen and ignored complication. Assessment of sarcopenia and frailty should be done in all patients with cirrhosis. It has emerged as independent predictor of poor prognosis in cirrhosis, as well as reduced survival post-liver transplant. With aggressive management, we might reverse sarcopenia and frailty and may improve the overall outcome of the patients. Thank you very much for your patience listening.